today's webinar, and I will provide you a brief COVID situation about China and Russia. So let's get started with China. China was the first country to identify the disease and its pathogen, the first country to impose drastic measures in response to the outbreak, including lockdowns and face mask mandates, and one of the first countries to bring the outbreak under control. The outbreak was first manifested as a cluster of mysterious pneumonia cases, mostly related to Guanan seafood market in Wuhan, the province of Hubei. The outbreak was first reported to the local government in the end of December 2019, and in the beginning of January 2020, a new coronavirus was identified as the cause of the pneumonia. The local government of Wuhan and Hubei were widely criticized for their delayed responses to the virus and their censorship of the related information during the initial outbreak. This allowed early spread of the virus, as a large number of Chinese people returned home from Chinese New Year vacation from and through Wuhan, as you know, which is a major transportation hub. However, strict measures such as lockdown of Wuhan and the province and face mask mandates were introduced in January, which significantly lowered and delayed the epidemic peak. By the end of January, the virus was found to have spread to all provinces of mainland China, and all of them had launched high-level public health emergency responses. By late February, the pandemic had been brought under control in most Chinese provinces. On mid-March, the reported number of newly imported cases passed that of domestically transported new cases for the first time. Sporadic local outbreaks have happened since then, which authorities responded to with testing and restrictions. Different neighborhoods were classified into high, medium, or low risk based on the number of confirmed cases and whether there were cluster cases, which formed the basis for the gradual easing lockdown measures since March. Lockdown in Wuhan was officially lifted on 8th of April 2020. Despite concerns about automated social control, health codes generated by software have been used for contact tracing, and only people with the green code could move freely, while those with red or yellow code needed to be reported to the government. In July 2020, the Chinese government granted an emergency use authorization for COVID-19 vaccines developed by Sinovac Biotech and the China National Biotech Group. The government also provided a vaccine developed by CanSino Biologics for use in the military. By mid-December, authorities said that over 1 million vaccine doses had been administered to over 650,000 people. By December, plans were in place to vaccinate more widely, beginning with high-risk groups. The vaccine rollout has been delayed by the limited supplies and vaccine hesitancy. As of February this year, China had provided vaccines to 3 developing countries and export to 22 countries. Last month, China reached 1 billion of domestically produced vaccine doses administered, representing more than 1/3 of the global total at that point in time. And this is about 74 doses per 100 population, a similar rate to the many European countries. That concludes my short brief about the snapshot about China. Virginia, back to you.
Thank you, sir.
No.
Thank you, sir. We're going to be moving on now to another country which similarly came out with vaccines very quickly in response to COVID-19, but has also been criticized in the past for a lack of transparency on its data. So over to you again on Russia.
So, Russia detected first coronavirus cases and consequently the outbreak relatively later than other European countries. It provided opportunities to analyze how the epidemic developed in the other countries and take timely measures to curb spread of the virus by reorientating the health system to effectively respond to the pandemic. Since February 2020, Russia has taken multiple steps to tackle COVID-19, including closing its long border with China and isolating early suspected cases. Authorities in the country have been using a largely localized approach, which each region responsible for its own measures, as well as several COVID restrictions were applied nationwide, including non-working period, which started on 30th of March 2020 and was prolonged twice, lasting until 11th of May 2020. Nowadays, Russia has again entered to the top 5 of the black list by number of infected with coronavirus. Actually, the country has the 4th highest number of COVID-19 cases in the world, surpassed only by the United States, India, and Brazil. The epidemic in the country is gaining momentum with the advent of the coronavirus Delta variant, as you know, first detected in India. Recently, the country battles the surging of this Delta variant. The main hotspots are the capital, Moscow, and Russia's second largest city, St. Petersburg, where restrictive measures have been tightened in the recent weeks. Daily new infections have more than doubled over the past month, soaring from around 9,000 in early June to over 20,000 in the past weeks. In relative terms, the increase in newly infected is 0.45%. Likewise, Russia ranks sixth in the world in the number of deaths during the pandemic, after United States, Brazil, India, Mexico, and Peru. Conditional mortality rate remained at the level of 2.47%. According to Moscow health authorities, the death rate in the capital in June this year increased by 24% compared to the June last year. Mortality from coronavirus in the capital is 2.78% if coronavirus was the only cause of death, or 3.88% if coronavirus was not the only disease. In Moscow and St. Petersburg, doctors and authorities are already talking openly about third wave. In many regions of the country, new stricter restrictions have been introduced, including compulsory vaccination. What else? In addition, some hospitals will again be set aside only for patients with coronavirus. Nowadays, hospitals are gradually overcrowding. A few weeks ago, the clinics were instructed to accommodate all patients with coronavirus over the age of 70. And now it is difficult to find the free beds. Authorities so far have been reluctant to introduce universal lockdown, such as last spring, in order to save the country economy. And according to doctors, however, there is hope that the number of infected will increase by the autumn, although this cannot be said with certainty. So this is that concludes my brief regarding Russia. Over to you.
Thank you, sir, for your presentation on Russia. And now we'll be moving towards Europe, and the presentation will be on Italy, provided by Ms. Stanislava Krainova.
Hello, everybody. Regarding Italy's situation, since the beginning of the pandemic, at least 1 in 14 residents have been infected. A total of almost 4,300,000 reported cases. At least 1 in 472 residents have died from the coronavirus. A total of almost 130,000 deaths. November 2020 was the worst month for cases, while December 2020 was the worst month for deaths in Italy. With regard to the hospitalization rates, as you can see, the coronavirus outbreak posed massive troubles in Italy. As the graph shows, the spread of the virus put hospitals and medical staff under a lot of pressure. As of July 12, 2021, almost 1,128 patients were hospitalized in Italy because of COVID-19. The highest figure since the start of the pandemic was registered on November 23rd, 2020, when 34,697 individuals were being treated in hospitals for COVID-19 related reasons. The resilience of Italian healthcare system and the limited capacity of hospitals were among the most challenging issues facing authorities. In the last months, however, the country started to see the end of this terrible situation. As of July 2021, the authorities administered more than 59 million doses of vaccines. Regarding the variants in Italy, the variant B.1.7, which was first identified in the United Kingdom, was prevalent in Italy in March 2021, according to the Health Ministry, where they also said that they were worried about the presence of small clusters of the Brazilian variant. Currently, a new study estimated that Italy ranks 5th in the world for the spread of Delta coronavirus variant. An Italian virologist even has predicted that the strain is set to become dominant in the country. The data from the past week showed that the nation's RT number, which shows the rate of transmission, had risen slightly to 0.66 from 0.63 last week. The incidence rate of cases per 100,000 inhabitants also is up from 9 to 11. So this is in short about the current situation, making an overview for the whole period from the beginning of pandemic till now. Thank you.
Thank you, Stanislava. We'll now be moving on to another EU country and our host country here of the CMDR COE, Bulgaria, presented by Major Gennady Kolev.
Thank you, Virginia. Thank you. Good afternoon, all. So the virus was confirmed to have spread to Bulgaria when the country's first cases, 27-year-old man from Pleven and 75-year-old woman from Gabrovo, were confirmed on 8th of March 2020. A year and 4 months have passed since we reached more than 420,000 registered cases, and this was a very traumatic period for the country. During this period, the government of the Republic of Bulgaria faced with the invisible enemy coronavirus. 3 waves were registered and respectively 3 times of lockdown. First lockdown, a ban of visiting parks, playgrounds and indoor and outdoor sports facilities took effect on 20th of March last year. It was forbidden to leave the regional centers in the country without valid reasons related to work, health reasons, or registration at a permanent or current address. With the continuing increase of COVID-19 cases daily, the Bulgarian government required on 1st of April that Parliament extend the state of emergency by 1 month until 13th of May. Following the state of emergency, the government decided to ease the measures after 2 months of restriction and deprivation. Most of them were removed, but some remained. The second lockdown was in place on 27th November until 21st December last year. The third lockdown, as of 22nd of March to 31st of March this year, physical visits to restaurants and entertainment establishments was prohibited in Bulgaria, and only home deliveries or takeaways was allowed. The restrictions also applied to hotel restaurants. Accommodation establishments remained open, but required to organize the delivery of food of their guest rooms, not in the common areas. So the country in transition expressed a serious problem related to the lack of adequate healthcare, financial resources for emergency response, organization of processes, and so on. A number of measures had been taken, whether timely or not. Many industries have been affected, and it is unclear when they will recover. So the process of recovery started slowly, but it needed time. The healthcare system was experiencing serious problems despite additional incentives from the government. Bulgaria came in one of the first in the black mortality statistic in Europe, with more than 18,000 deaths, which is 4.3% of total cases. People were dying in front of the hospital in search of help. Doctors were in short supply, and students and volunteers took their places. Clusters was not adequately monitored, leading to diffuse spread of the infection during the peaks of the waves. Today we can see light in the tunnel due to the steadily decreasing new cases on a daily basis, less than 100 from 1 month until now. But this should not reassure us too much. We will go a long way until we reach the desired end state. That is my summary for the whole period. Over to you, Virginia.
Thank you, Major Kolev. We'll now be moving on to Romania, a recent sponsor country for our center, and that will be presented by Lieutenant Colonel Sasha Alexandrov. Over to you.
Thank you, Virginia. Thank you. Hello, everyone. I'll brief you about Romania, how COVID progressed in Romania. Romania has administered at least 9 million doses of COVID vaccine so far. So we have fully vaccinated about 24.2% of the country population, which is exactly 4.7 million people. And also we have 25% with one dose. Romania so far approved 4 vaccines. These are Pfizer BioNTech, Moderna, AstraZeneca, and Johnson & Johnson. By percentage, 76% is used by from Pfizer BioNTech. Moderna is 7.5%, and AstraZeneca is about 9%, and the last one, Johnson & Johnson, is 7.6%. So about the testing process, the number of recorded COVID-19 tests increased after the methodology has been changed. It means that it been included rapid test as well. So the number of COVID-19 tests carried out was too small compared to the real number of cases. This is why the legislation in the area was recently changed, allowing rapid tests to be included in the official reports. The measures applies only to tests carried out at labs and inside medical units. Once this platform of the special communication system was updated, the number of cases and tests increased. So the Romanian national authorities are constantly trying to increase the testing capacity for the coronavirus infection. The drastic evolution of the virus spread resulted in total of nearly 8 million tests carried out by the 8th of July 2021. So, according to COVID-19 progress, the following measures have been applied. First, a recovery plan against the pandemic has been issued, and the Romanian government has imposed the following measures. These are social measures, direct and indirect tax measures, economic stimulus measures, employment-related measures, and custom measures. Social measures, when I'm saying I mean ban on public gatherings, schools and border closures, lockdowns and mask wearing. The best key tax measure which has been imposed is all tax obligations after 21st of March 2020 were not subject to late payment, interest and penalties. Economic measures, I mean loans and moratorium on debt repayments. About employment measures, state compensation scheme, for instance, covering 75% of the salary of employees if their activities is interrupted. And custom measures, exemptions from custom duties for certain products constituted as medical emergency stocks by the emergency department within the Ministry of Internal Affairs. That is in short for Romania and COVID-19. Thank you, Virginia. Over to you.
Thank you, sir. A reminder to all participants to try and keep within the 3 minutes allotted to you for your schedule. We are now moving on to another sponsor country, a fellow EU neighbour, Poland, presented by Colonel Darius Sobron. Thank you. Over to you.
Thank you, Virginia. Thank you, Mehmet. Good afternoon. So without any ado, let's start. The first case of COVID-19 in Poland was recorded on 4th of March 2020, when so-called patient zero was diagnosed positive after arriving from Germany. The development at the beginning of the situation in Poland was influenced by numerous arrivals of infected people from various countries from Europe. Mainly, this was the part of the Fly to Home campaign, which was done by the Polish Airlines when they completed more than 400 arrivals of flights from 70 destinations from all continents. And until mid-March 2020, about 30% of all diagnosed cases, there were patients who became infected abroad and then came to Polish territory. In March 2020, the most frequent introductions took place from Austria, France, Great Britain, Germany, Spain, and Italy. On 12 March last year, the Minister of Health introduced an epidemic emergency in Poland, and unfortunately, the same day, the first fatal case of coronavirus in Poland was recorded. From 16 March, all Polish borders have been completely closed. They can be exceeded only in the designated places and on specific, of course, sanitary regime terms. A strict border and sanitary controls were introduced, and every Polish citizen who is coming back must undergo a mandatory 14 days quarantine. Foreigners were banned from entering Poland for 10 days at the beginning, and the same day all schools, universities and education places were closed. Poland introduced a very similar to other countries system of testing people and introduced very quickly package of restrictions up to the full lockdown. At the beginning, only molecular PCR tests were done. However, there were limited number of laboratories which were able to do it. And many times the tests results were wrong or at least ambiguous. And time from taking the sample to receiving results were quite long one, which caused by keeping people in a long quarantine. Nevertheless, getting more and more experience in that domain, entire system was developed enough to provide testing possibilities for any who must or want to do it. Measures and restrictions which were introduced are typical for such disaster, and Poland was not different from other countries. However, almost half the population claiming that they were too restrictive, killing small businesses and bringing no visual solution for citizens. Nevertheless, due to such restrictions, first wave of pandemic was suppressed, but this was only apparent success. During summertime, most of restrictions were lifted or at least limited, and the Prime Minister even announced that the pandemic is over. This was mostly due to the presidential election and huge pressure to conduct it in the standard way. Also, as a mistake was taken coming back to residential teaching just after vacation. All those decisions and overall situation in Europe caused second wave of pandemic, which was more and much more severe and in particular deadly. So up to now, almost 2.9 million cases are officially recorded in Poland, which is about 7.6% of population.
Thank you, sir. We're running out of time for your allotted slides. Maybe your concluding sentence on Poland?
Concluding sentence, okay. So far we noticed almost all types of mutations of the virus. However, the majority of them is so-called British one. But of course, recently the most concern is about the Indian or called Delta as in the other countries. That's all. Thank you so much.
Thank you, sir. Okay, we're moving on to our last EU country, Germany, presented by Colonel Greventopoulos. Sorry if I mispronounced your name. Over to you.
Okay, thank you very much, Virginia. I will brief you about Germany. The first case in Germany was recorded on January 27th of 2020. It was a 52-year-old man from Munich who had contracted the infection for a Chinese colleague. As of mid of July, Germany has the 12th most coronavirus confirmed cases worldwide. As you can see on the left side of the slide, the total numbers are over 3.7 million confirmed cases and more than 91,000 COVID-related deaths, with a fatality rate of approximately 2.5%. At the same time, more than 3.6 million Germans have recovered from the virus infection. On December 30, 2020, daily reported cases in Germany reached the maximum since the start of the pandemic, with almost 50,000 new cases. And furthermore, on January 14th, a daily record of more than 1.2 thousand deaths. Since the outbreak of the coronavirus, Germany has been trying to flatten the curve of new infections so that the healthcare system is not overloaded. Encouraging people to stay at home and placing restrictions on public life are the most important measures that Germany took. At the same time, thousands of additional intensive care beds have been created in Germany. When coronavirus infection numbers started to rise during the second wave, the German states introduced new restrictions in November 2020. Germany, characterized as a role model for countering the first wave of pandemic, but this was no longer true for the second one. Germany had hoped that a partial lockdown to sustain the economy would be the best way to tackle the second wave too, but the infection rates and the number of people dying from COVID remained high. That imposed a harder lockdown, a full lockdown, that was agreed on December 2020 as unavoidable and lasted until May 2021. The pandemic brought about new challenges, such as the lack of sufficient availability of the market of protective equipment, the need of medical supplies, doctors and medical staff. But the healthcare system in Germany is one of the best in the Europe, and it succeeded managing the COVID pandemic very well. Something to notice is that Germany is one of the world's fastest growing digital healthcare markets. Based on a report by a research company, the annual digital healthcare spending will rise to around 40 billion euro by 2030. More than 80% of digital healthcare startups in Germany consider COVID to be an opportunity rather than a threat to their business. And last bullet about the variant of COVID. According to ECDC, the Delta variant is almost 60% more transmissible than the Alpha and may be associated with higher risk of hospitalization. Based on the estimated transmission advantage of the Delta variant in Germany, 70% of new infections are projected to be due to this variant in Germany by early August, and almost 90% of infections by the end of the same month. Modeling scenarios indicate that any relaxation over the summer months could lead to a fast and significant increase in daily cases in all age groups, with an associated increase in hospitalizations, deaths potentially reaching the same levels of winter 2020, if no additional measures are taken concerning the Delta variant. That concludes, Virginia, my presentation. Over to you. Thank you.
Thank you, Seth, for your presentation on Germany. Next up, we have my own country, which, as a British national, I'm proud to present. Although I wish it was in a happier mood. These are the latest figures from the UK government on the situation. As you can see, the number of people testing positive for COVID is going up, as is the number of patients admitted and deaths. It's also notable that the vaccine progress in the UK is very high in comparison to many other countries, as you can see on the infographic on the bottom left. And what I thought was most striking, considering the high amount of concern for the Delta variant right now, is that the amount of deaths is not as significant as it would initially seem. Of course, they are rising, but as you can see on the bottom right graph, you can see the different waves of COVID since the beginning of the pandemic. And we see that the rise in deaths is not as significant as it might seem with the Delta variant. One of the most interesting things about doing this presentation today is that today is the so-called Freedom Day, as declared by anti-lockdown protesters, in which legal measures forcing you to enforce COVID mask wearing and things like this are being relaxed today. And so for that reason, there's still a lot of concern about the rising number of cases, mostly in youth, in the 20 to 29 age bracket. So click on the next. Okay, so I thought it would be interesting for you all to see what this third wave really means in comparison to the second wave, and significance for the Delta variant, which we know is 40% more transmissible than other variants of the past. And we also know now that it represents 99% of cases in the UK currently. So I think this is in a way trying to convey some slight optimism that vaccine progress vaccines are working, and that's really still considered by the UK government to be the best way forward. Testing in the meantime has also increased significantly. I myself know many people that are getting tested multiple times a week to go into work. Schools are being forced to shut their doors to certain classes when someone's been notified that there is COVID presence and there was potential contact. So things seem to be under control. But we will see how the situation develops. So that's it from me. And now we'll be moving over to our American cousins, which will be presented by Lieutenant Colonel Svetlana Panovsky. Thank you.
Good afternoon, Virginia. Good afternoon, everyone. I'll start with USA. The first American case was reported on January 20th, and the President Donald Trump declared the US outbreak a public health emergency on January 31st. Restrictions were placed on flights arriving from China, but the initial US response to the pandemic was otherwise slow in terms of preparing the healthcare system, stopping other travel and testing. Meanwhile, Trump remained optimistic and was accused by his critics of underestimating the severity of the virus. A second rise in infections began in June 2020, following relaxed restrictions in several states, leading to daily cases surpassing more than 60,000. A third rise in infection began around mid-October, leading to daily cases reaching over 100,000 by the end of the month. A fourth rise in infections began around late March 2021, and is the rise of the Alpha variant. High levels of vaccine hesitancy in parts of the country have hampered vaccination efforts amidst the rise of the Delta variant. This led to a fifth rise in infections, with the vast majority of new cases being among unvaccinated people. Disproportionate numbers of cases have been observed among Black and Latino populations, and there were reported incidents of xenophobia and racism against Asian Americans. The US has about one-fifth of world's confirmed cases and deaths. Coronavirus cases, hospitalizations, and deaths have been steadily declining since April, a testament to the effectiveness of the vaccination campaign, but have now begun to trend slowly upward. For the first time in 3 months, coronavirus cases are rising again. The currently daily cases rate is up 111% on the previous 2 weeks. National hospitalization numbers are beginning to rise as well. The high transmissible Delta variant is now the dominant coronavirus strain in the US, surpassing the Alpha variant. Delta variant represented 52% of new cases in the US over the 2 weeks ended July 3rd. Meanwhile, the proportion of new cases caused by Alpha was just 28% over the same time period. In parts of the US, Delta strain accounts more than 80% of new infections, including some Midwestern states such as Missouri, Kansas, Iowa. The Delta variant is already causing 74% of infections in Western states, including Utah and Colorado, and 58% of infections in Southern states such as Texas, Louisiana, Arkansas, and Oklahoma. As the coronavirus Delta variant rapidly spreads, US hotspots have seen rising in cases. That's all from me. Thank you. Over to you.
Thank you, sir. We now move on to Dejan Ivanov presenting on Brazil.
So, good afternoon. I will present you Brazil. During the last 6 months, the infection rate remained stable without any significant fluctuations, around 50,000-60,000 people per day. There were 2 peaks of infected people. The first one was in January 2021 with 87,000 people per day, and the second in June with 140,000 infected people for a day. Gamma variant, also known as lineage P.1, is one of the variants of COVID-19. This variant was first detected by the National Institute of Infectious Diseases, Japan, on 6th of January in 4 people who had arrived in Tokyo, having visited Amazonas, Brazil 4 days earlier. It was subsequently declared to be in circulation in Brazil. Gamma caused widespread infection in early 2021 in the city of Manaus, the capital of Amazonas, although the city had already experienced widespread infection in May 2020. The COVID-19 vaccination campaign in Brazil is an ongoing mass immunization campaign for the COVID-19 pandemic. It started in January 17, 2021, when the country had 210,000 deaths. The country's role in research helped it cut 2 deals to get preferential access to possible vaccines. One such agreement is between the state of Sao Paulo and China's Sinovac for 46 million doses, and another is between the federal government and AstraZeneca for 100 million doses. Both vaccines would be produced by Brazilian manufacturers. As of July 20th, 2021, About 30% of the Brazilian population have been fully vaccinated, and 35% have been received the first dose of any of the vaccines. According to some researchers, 70% of population will be vaccinated after 329 days. Brazil's chaotic response has deepened political polarization among supporters and critics of the president. Hospital systems have largely coped with the crush of patients, but the virus has taken a devastating toll on healthcare workers. Dozens of nurses and hospital technicians died after contracting the virus at work. Instead of the conclusion, I will note the thoughts of Professor Halal, an epidemiologist leading the largest COVID study in Brazil, says his country has been a laboratory for everything that could be done wrong in a pandemic. The result, according to his research, is 400,000 deaths that could have been avoided, a quarter of them caused by the failure to sign vaccine contract last year. Everything that you should not do, he said, Brazil has done. That is for Brazil. Virginia, over to you. Thank you.
We now move over to our penultimate country, India, covered by Lieutenant Colonel Visaslatkov. To you. So sorry, Mexico.
Thank you, Virginia. The COVID pandemic in Mexico is part of the ongoing worldwide pandemic of the coronavirus disease. On February 28th, Mexico officially confirmed its first 3 cases, 2 cases in Mexico City and 1 case in the northern state of Sinaloa. On February 29th, a 4th case was detected and confirmed in the city of Torreon in the state of Coahuila. The situation developed very slow in the beginning, but in April, the first wave of the pandemic began, and the number of cases reached its peak around 10,000 cases per day in August 2020, and the total number of cases reached 500,000. After the peak, the number of daily cases kept the level of around 6,000 per day till the end of the year. After that, a second wave began with a peak of 22,000 daily cases on 22nd of January 2021. After that, the situation started to calm down until May 2021. Since the 1st of June, it seems that Mexico entered third wave of infections with COVID-19, and currently the new daily cases are above 11,000. The current infections level is around 2,660,000, which constitutes around 2% of the population. The death rate is around 9% or 236,000 death cases, but this is the official data. The government admits that the real numbers are much bigger, and the death cases are around 320,000, which makes death rate around 12%, which is a very high level. Despite of the increase of the numbers of the new infections in the last weeks, the hospital beds occupancy is low and is in the level of 25%. According to the model developed by the authorities for the third wave, the number of occupied hospital beds will not exceed 3,500. For comparison, in the second wave, the number of occupied hospital beds was more than 8,000. Mexico death toll exceeded levels originally conceived as catastrophic by local health authorities. but what's scary is how many COVID-19 patients in Mexico are dying before being connected to ventilators. According to Mexico's public available epidemiological oversight, only 20% of the country's COVID-19 patients who died were intubated. More than 50,000 COVID-19 patients never received ventilator treatment before they died. Thousands of COVID-19 patients died every week without any access to the type of any intensive care. About the COVID variants, it has been detected that 24 variants of COVID-19 are circulating in the country, with Alpha, Gamma, and Delta being ones with the greatest presence in the national territory. However, the Delta still has a smaller proportion. According to the information from the last 8 weeks, the variant that has been detected with 31% of sequence continues to be variant B11519, which is being monitored globally. However, it is possible that this variant has been replaced in Mexico in the coming weeks by others, such as the Gamma variant, which already reached 23% of the reported sequences.
If you can please give your concluding remarks for this, because we've gone over the time.
Yes, it is said that the level of testing is very low, and the vaccination reached the level of 16% in Mexico, which is also very low. Thank you.
Thank you, sir. Apologies about the country confusion before. We're now moving on to India, which is actually our penultimate country, presented by Lieutenant Colonel Demarkov. Thank you. Over to you. I'm reminded to keep it within the time limit. Thanks.
Good afternoon, everybody. I will shortly present here India to you. As of 7 July, India has over 30.5 million COVID-19 cases, which makes it the second worst affected country in the world after the USA. In early March, the case began to increase very rapidly until the beginning of May, when India had for several days more than 400,000 daily new cases, first in the world. The central government invested a lot of efforts to properly manage the pandemic in the big urban areas, but in the rural areas, people very often had to deal with the disease on their own and to survive as they can. All COVID-19 variants are presented in India. The second wave that devastated the country is largely attributed to the Delta Indian variant. Totally 286,075 million, 20.78% of the population is vaccinated. 2 locally made vaccines, Covishield and Covaxin, are used, and also Russian-made Sputnik V. High levels of vaccine hesitancy among the population, especially high up to 40%, is the hesitancy among the elderly people and India's low caste Dalits, 200 million people. The Indian government invested significant effort to manage the crisis. Very hard restrictions were imposed when the number of cases was extremely low, and this caused economic crisis and enormous difficulties. The authorities always advised precautionary measures as social distancing, wearing of masks, and mass vaccination. On 24th March 2020, the Prime Minister announced a total lockdown in India, except for hospitals, grocery stores, and pharmacies. The much more severe second wave of the pandemic in India has seen no nationwide lockdown. At the beginning of the pandemic, testing was not accessible for the majority of the population, but by 5th May 2021, and currently India is capable of conducting 2.2 million tests daily. Indian authorities were not hiding or misinterpreting information. Between the first and the second COVID-19 wave, India was providing millions of vaccines to neighboring countries and also to different poor countries worldwide. Later on, the country limited its vaccine export and banned the export of COVID-19 drugs.
Sorry, sir. Can we get your concluding remarks in order to keep the timings?
Yes, of course. So, lastly, but not least, lessons identified. Avoid overconfidence. Testing is key to controlling disease. No substitute for mask, hand hygiene, and social distancing. Lockdown does not break chain transmission. Indian cities were the most vulnerable. Young people spread the most, suffer the least. The importance of building the capacity for COVID-19 prevention and control various foreign workers from different sectors, health, education, nutrition, and so on. When COVID-19 cases are low, prepare for the next wave. Back to you.
Thank you, sir. And now we move on to the final country of this panel, which will be covered by Lieutenant Colonel Valentin Parvanov, who will be taking on the challenge of discussing the African continent.
Yes, thank you very much. So I'll try to fit in those 3 minutes. Well, the COVID-19 was confirmed to have spread to Africa on 14th of February 2020, with the first confirmed case announced in Egypt. In the whole Africa, the cumulative number of confirmed COVID-19 cases is more than 6 million. The total number of deaths exceeded 152,000 cases, which is approximately 2.7% of case fatality ratio. And more than 5.2 million people have recovered. This represents 3% of all cases and 4% of all deaths reported globally. 21 countries are reported CFR higher than the global ratio. 53 countries have experienced at least a second wave, while 42%, which is approximately 23 countries, have experienced a third wave. Talking about third wave now it has been seen in Africa, and cases are rising faster compared with the previous waves. Over the past month, Africa recorded an additional 1 million cases, which is the shortest time ever it has taken to add another million cases. The number of new cases daily in the ongoing third wave is higher than what was reported at the peak of the second wave. During the second wave, daily incidence peaked at 28 cases per 1 million, and now it is 33 cases, and it's growing up. All countries in the African region are experiencing community transmission, of which 6 countries have uncontrolled transmission, which is quite disturbing. At this point, 39 states in Africa have reported the presence of Alpha variant. 29 countries have reported Beta variant, and 15 countries have reported Delta variant of concern. The Delta variant, along with the colder seasonal weather in South Africa, is spreading to a growing number of countries and is now dominant in South Africa. I would like to stress out some concerns about the virus. I will mention some and I will explain in a minute for another ones. Some of them are in that inoculation process started 2 months later than Europe. Inequality of vaccines, distribution, lack of vaccines, especially this one I want to stress out. Most African countries have got their vaccines under COVAX program, and these were largely sourced from the Serum Institute of India. Meanwhile, many African countries followed advice from World Health Organization to administer as many first doses as possible and not stockpile vaccines for second doses. Some countries has also been under pressure to use vaccines urgently of risk of passing their expiration dates. However, India halted vaccine exports in response to their own urgent needs, and manufacturers faced issues with ramping up production in a short space of time. Another major concerns that the approach of the lockdowns governments have imposed. Accountable governments have imposed popular support and measures to fight against the crisis. But for the more authoritarian governments or ones which with security services not under democratic control, imposing a lockdown was an opportunity to exploit. From a number of countries, Uganda, Burundi, Guinea, and so on, there are stories of people being arrested, beaten, imprisoned, and even raped for breaking curfews. Shortly, another major concern is that Africa lacks sufficient health workforce and remained a spectator of research and development with regards to anti-COVID-19 efforts. And there is a risk more and more Africa could fall into power, but I believe I don't have time to explain that. And at the end, one very important concern that many African states are relying on COVAX program only, which turned up to be a mistake. And I'm going to speak on a panel to how the continent is dealing with this issue. Thank you very much. Virginia, over to you.
Thank you, Valentin. I took the liberty of taking over Virginia and thanking everyone part of this panel. We will please, if you have any comments or questions, you can use the chat box to post them there, to leave them there. And then we will address them during the third panel or the so-called final discussion panel. So please use the chat or just then use the function, the raise hand function during the final discussion. But now, please take a 10-minute break and be back at quarter to 2 your time. So a 10-minute break. See you in 10 minutes for our second panel. Thank you very much. So welcome everybody back from your coffee break. Hope you had a chance to grab something to drink because now we are entering into the second panel of today's webinar. And that is, after seeing what the issue at hand is, we're now moving to assessing what the solutions have been and what potentially could be improved. And it is my pleasure to pass the floor to Mehmet, who is going to be your moderator for this second panel. So Mehmet, over to you.
Thank you, Gergan. So we will start with the list of countries, and afterwards we'll include a few supranational organizations on this panel. So up first, we will be starting with Spain, and we pass the floor to Stanislava Krajnova.
Good afternoon, everybody, again. Regarding the assessment part of this panel, I will talk a little more about the gaps, the identified gaps, and in the measurement of cases and the misleading threats. But first, starting with the vaccination trends in Spain, it is important to note that at least 50,239,000 doses of COVID vaccines have been administered so far. Assuming that every person needs 2 doses, that's enough to have vaccinated about 53.4% of the country's population. As I've mentioned, there are some measurement gaps regarding the identification of cases in this country. Researchers and scholars have identified reporting anomalies in the methodology of data collected by the end of 2020. There are also some misleading trends. For example, in June and December 2020, Spain added many deaths that were not properly recorded from earlier in the pandemic. Spain does not regularly report the new data on weekends. The officials in Madrid and regional governments often revise data or report a single-day large increase in cases or deaths from unspecified days without historical revisions, which can cause an irregular pattern in the daily reported figures. There are also some healthcare system gaps identified due to the decentralization of Spain's healthcare system and the lack of nationwide homogeneous strategy. One of the general reasons for that is that Kingdom of Spain is a federal state and regional healthcare systems differ widely in terms of organization, methods of staging the casualties, equipment, and medical workforce. So this is in short about the identification of the gaps regarding the COVID-19 situation in Spain. Thank you. I pass the floor to you.
Thank you, Stanislava. And now we will proceed with the Republic of France. And over here, we will the presenter will be Lieutenant Colonel Biser Zlatkov.
Thank you, Mehmet. France is one of the most severely hit by COVID-19 countries. The country ranks the 5th place with the infections, with around 6 million COVID-19 positive cases. Since the beginning of the pandemic in France, France started with restrictive measures. On the 12th of March, it was announced all schools and universities were closed. On 13th of March, pubs, restaurants, and cinemas were closed. On the 17th of March, a national lockdown started. It lasted until 11th of May, and in June, July, it started gradual easing of the restrictions. but in October 2020, a second national lockdown was announced, and it started since the end of October. In April, a third national lockdown started, and since 29 of April, President Macron announced date for easing of the restriction of this third national lockdown. On the slide, you can see the graph of these measures. Despite of these very restrictive measures, France is one of the countries with such kind of restrictions. You can see that the level is of infections and deaths is very low. So it is very questionable how effective these measures were. About the vaccination, the current level of vaccination is around 40%. 40% of population is fully vaccinated. The vaccinations, the campaign is in 5 phases. The first phase started in December 2020, and it concerned people over age of 50. The second phase concerned people of high risk, and it started in January 2021. These are people age 75 and over who do not reside in special care homes or nursing homes. In phase 3, it concerns people aged from 50 to 64. And
due to the expiration of the given time, could you tell us your final assessments on the measures?
Okay. The final phases of vaccination will be open to younger people over 80. The vaccine used in France are Janssen, AstraZeneca, Moderna, and Pfizer. Thank you.
Thank you, Lieutenant Colonel. Now, up next we have Lieutenant Colonel Efthymios Grivantopoulos presenting his home country, Greece.
Okay, thank you, Mehmet. About Greece, the first doses of Pfizer-BioNTech coronavirus vaccine arrived in Greece at Christmas Day 2020. Started from the previous week, the Greek government approved vaccination for teenagers over 15 years old. As you can see on the slide on the left side, more than 5 million Greek citizens, that means more than half of total population, has been vaccinated with at least one dose. And around 44% of population has completed their vaccination. The vaccines used in Greece are those approved by the European Medicines Agency, Pfizer, Moderna, Janssen, and AstraZeneca. In Greece, there is a significant part of the population that is skeptical about doing their vaccination, like in every other European country. Generally, there are a mix of people, including conspiracy theorists and anti-vaxxers, as well as supporters of alternative medicine. In this way, and in order to keep the vaccination rollout at current level, the Greek authorities decided early this month, July, to take some measures. First of all, the vaccine will be now mandatory for all Greek healthcare workers, also for all those who work in healthcare facilities. Second, and since the country reopened earlier this summer, enclosed spaces such as movie theaters and indoor sections of bars and restaurants have remained closed. From now on, those establishments will reopen, but only for those who have been fully vaccinated. Also, in order to prevent further spread of the virus, all visitors at bar, restaurants and cafes will remain seated. To conclude about vaccination increase, the continuation of vaccination progress at current levels is critical in order to keep the incident levels at low numbers. To encounter the pandemic, Greece took restrictive measures in 3 periods, each one for the 3 waves of the pandemic: March, November 2020, and last at February 2021, including full lockdown and night curfew. Moving now and last to COVID testing in Greece was accessible and affordable almost like in any other EU member state. You can see on the graphs in the right part of the slide the daily new tests conducted from the beginning of the pandemic. And on the right down diagram, the positivity rate of the test, which top figure was more than 10% during November 2020, and for the last week was around 3.5% of total tests, which number maybe indicates the beginning of the 4th wave of the pandemic in Greece. That's all from me. Thank you, Mehmet. Back to you.
Thank you, Lieutenant Colonel Grivantopoulos, for your insight on Greece. Now we will have a very interesting case in the face of Sweden. I pass the floor to Lieutenant Colonel Damakov. The floor is yours.
Good afternoon again. I will try to brief you as shortly as possible, but I ask for 1 or 2 minutes more because Sweden is one of the most controversial countries in regards of its approach. So the Swedish... Do you read me over?
Loud and clear, please continue.
Thank you. The Swedish society, in the Swedish society, there is a general, relatively strong trust in government agencies. According to a research since March 2020, most central institutions in Sweden have seen trust and support from the public. In Sweden, crisis management is built on the principle of responsibility, personal responsibility. Independent expert government agencies give the government advice about which measures are needed to limit the spread of COVID-19 and combat the effects of the spread of infection in the country. Swedish government has presented many different measures with the aim to limit the spread of infections in the country, ensure healthcare resources are available, limit the impact on critical services, mitigate the effects on people and businesses, ease concerns by providing information. Sweden's response to the coronavirus pandemic is about taking the right measure at the right time. It's also partly based on voluntary action. Swedish COVID-19 vaccination started in December 2020. On January 10, 2020, Sweden implements the temporary pandemic law, giving the government more legal powers to limit the spread of COVID-19. The law makes it possible for the government to take measures such as introducing limits on visitor numbers or opening times. The Public Health Agency of Sweden has made the assessment that closing all schools in Sweden would not be a meaningful measure. This is based on an analysis of the current situation. In March 2020, a new law came into force. The law makes sure that there is a child care available for children whose parents have vital public functions, such as in healthcare or the police force. Well, what's the real lesson of Sweden's so-called laissez-faire or hands-off approach? The COVID-19 pandemic, now in its 2nd year, has prompted a great deal of debate and reflection on the tensions between personal civil liberties and the collective good. Some scientists have also joined the fray and favor looser measures in order to preserve civil liberties and to attain herd immunity as a byproduct. Sweden figures in all this because of its largely voluntary approach to quarantining and social distancing. The white touch approach should have provided Sweden with greater protection in the 2nd wave vis-a-vis its Nordic neighbors, who offered for conventional strategies. So, has this hypothesis been upheld? The answer is deliberately no. If they had been correct, excess mortality in Sweden should have peaked lower in comparison to that of the other Nordic countries. In fact, no such thing happened. Faced with such sobering statistics, champions of hands-off approach should have responded to it humility. Yet instead of adapting their hypothesis to fit the facts, they disregarded the numbers in order to suit their beliefs.
So, due to the lack of time, can we have your final conclusions?
Yes, I'll conclude. Many countries have both marveled and criticized the Swedish strategy that is formed in a close partnership between the government and the society based on a mutual trust, giving the responsibility to individuals. It already highlights how much can be achieved with voluntary measures or recommendation. Back to you.
Thank you, sir. Very interesting approach indeed. I see parallels of the experts' advice to the government, like the one in New Zealand. Now, up next, we will have Serbia with Lieutenant Colonel Sasha Alexandrov.
Thank you, Mehmet. Thank you. Hello, everyone. Again, I'll brief you about Serbia and COVID-19. Currently, the situation is stable with a further decreasing tendency of COVID-19 incident rate in all parts of the country, of course. However, the COVID-19 is still circulating in the territory of the Republic of Serbia. The figures that you see on the slide shows the line of new cases since the first case of the pandemic. So we have two peaks, one at the beginning of December and the 2020, and the second in April 2021. About the hospitalization, Serbia literally has 4 clinics for infection disease, as well another 7 hospital centers in Belgrade, Niš and Novi Sad reconstructed for the treatment of COVID-19 patients. In addition to that, in collaboration with the Army, several fair and sport halls have been repurposed to be improvised temporary hospitals for patients who have mild forms of disease. Also, additional facilities have been refurbished to add capacity and new hospitals have been built. About the mortality rate in Serbia has increased in the pandemic. The greatest number of deaths in Serbia, as you see in the chart, was recorded in December 2020. So, of course, these statistics sometimes includes all patients, not only those who were sick from COVID-19. And currently, the mortality rate is 0.99%. COVID variants. So doctors in Serbia extremely worried about the British, South African, Brazilian, and Californian variants of the coronavirus, as well as the Indian double mutant. These variants are transmitted faster, they are potentially resistant to antibodies and interfere with the diagnostic process. The only reported variants, 2 people in Serbia have been diagnosed with the more infectious Delta coronavirus variant. This is the COVID first such case on 1st of July 2021. So as a conclusion, I would say that Serbia has not been significantly affected by different COVID-19 variants. That was all from my side. Thank you, Mehmet. Over to you.
Thank you for your insight about Serbia, sir. Up next, we will have Russia again, but on a different approach according to the second panel. We'll have Lieutenant Colonel Nikolai Parvanov again, and he will explain us about their approach to the virus in a good way. The floor is yours, sir.
Thank you, Mehmet. Without any further ado, I will start with Russia, and then I will continue with Israel. As we have seen from the previous panel, Russia is getting in third wave. Actually, for the first time in the pandemic, the daily death toll exceeded 700 and has remained at that level ever since. Russia is one of the first countries which developed COVID-19 vaccine. There are currently 4 vaccines offered in Russia. Sputnik V is the most widely available, and there are also Sputnik White, which is a one-shot vaccine, Epivac, Corona, and Covivac. Foreign vaccines are not yet available in Russia as they have not received official approval. It could be at least a year before they come to market. Russia's vaccination rate is, in the meantime, have fell behind compared to the other nations. Currently, 29 million Russians, or just 20% of the population, have received at least one shot of a vaccine. In light of the surge and low vaccine uptake, authorities in nearly 30 Russian regions have made vaccination mandatory for certain groups of people, like those employed in healthcare, education, retail, public transport, government offices, and services sector. Moscow and the region surrounding it were the first to announce the measure a month ago. Otherwise, employers would have to suspend unvaccinated workers without pay and face steep fines. So far, at least half of adult Russians still reject the vaccine, even if polls indicate growing trust. Many say that they want to know more about the results of studies before getting vaccinated, voicing concern over side effects. Now let me go ahead with the next country, which is pointed out as a role model in vaccination progress, Israel. As a part of the worldwide pandemic of coronavirus disease, Israel has faced 3 waves by now. The first wave began on 21st February 2020, when Israel confirmed the first cases of COVID-19. Soon after the first cases, the government initiated extensive information campaign by setting up a multilingual website with information and instructions regarding the pandemic. The restrictions were severe, and most prominent of them were mobile phone tracking of affected individuals, public transportation curtail, closure of cities and neighbors. On 14th of March 2020, Prime Minister Netanyahu announced new regulations and stated the need to adopt a new way of life. This included banning gathering of more than 10 people and closure of all educational institutions. During the first wave, the country held election day, and conjunction with Passover feast provided in a 3-day national lockdown. The second wave started at the beginning of July, when over 30,000 Israelis were ordered into quarantine. On 6th of July, following over 2 weeks of continued increase in the number of new cases, Netanyahu announced new social distancing guidelines by the government. The second wave was accompanied by protests against Netanyahu due to pressure from business owners. The government backtracked on the closure of restaurants, pools, and beaches. Weekend closure of malls and markets were also cancelled, following claims that the closure had not slowed infection rate. In December 2020, the third wave was announced. Cases steadily increased, reaching over 3,000 new cases daily and over 5% test positivity rate. restriction for the second wave schedule, and some were even more severe, like traveling limited to 1 kilometer radius from home, visiting another person's home was forbidden also, and public transportation was reduced up to 50%. Vaccination, actually, the vaccination began on 19 December 2020.
I'm so sorry to be interrupting you, but if you could please move towards your concluding remarks, that would be highly appreciated. Thank you.
Okay. I would like to say that following the national vaccination campaign, Israel reached a vaccination rate over 60% of the population and 9% of COVID-19, with resulting drops in new cases and deaths. That's all from my side. Thank you for your time.
Thank you very much, Nikolai. It is good to hear examples about successful cases in terms of vaccination. And I wonder whether the studio is ready to rejoin the discussion. If not...
Sorry about having small technical difficulties. Thank you, Lieutenant Colonel, for covering your second country, Israel, here as well. Indeed, a very interesting country from which we can learn a lot of lessons. Now, we will continue with the United States again, and we will see their approaches and policies on dealing with COVID-19. The floor is given to Cvetan Panovsky. Thank you.
Thanks, Mehmet. Good afternoon, everyone. I'll continue with second part of the United States. The COVID-19 vaccination campaign that began in December 2020 can be counted so far as a victory. The states that have administered the highest number of vaccinations are California, Texas, and New York. The share of US population fully vaccinated against COVID-19 has reached around 48%, and 68% of adults have received at least one shot. While vaccination continues, the rate of people being vaccinated has been declining since a high in April. In chat box, I saw one question about the lack of interest for vaccination, and what could I say about the United States, that the spread of misinformation and conspiracy theories has the potential to harm the immunization campaign. As of June 8, 2021, 1 in 5 people in America reported that they are not at all likely to get the vaccine. Those who do not want currently to be vaccinated list a range of reasons why. Majority of people pointed that on the first place they pointed the side effects expected from the vaccine. On the second place, they mentioned a sense that vaccines were developed and tested so quickly. And on the third point, they pointed a desire to know more about how well they work. The US has conducted more tests than any other countries. Tests are available at no cost at health centers and selected pharmacies. Families First Coronavirus Response Act ensured that all people in the United States have access to pre-test, including the uninsured. The United States government and many states have taken drastic measures to curb the spread of the virus. Throughout the coronavirus pandemic, it has been up to states and local officials to determine what restrictions to impose to slow new infections. Many states had ordered full shutdowns, ordering the closure of bars and restaurants, banning public gatherings, closing schools, and requiring residents to stay at home. Major public events had been cancelled. Several sports leagues, including the NBA and NHL, had suspended their seasons. Now, states have moved closer to lifting all restrictions on businesses and gatherings as the vaccination campaign has progressed. A full reopening still comes with rules in many places. A few conclusions about the United States. We have seen the success of vaccination programs over the past 8 months, with cases, hospitalizations, and deaths far lower than the peaks we saw in January. We are starting to see some new and concerning trends in areas of low vaccination coverage. Cases and hospitalizations are up. Highly contagious Delta variant is spreading rapidly throughout the country and poses the greatest threats to social life and economic development of the country. Black and Latino Americans once again have the highest death rates from COVID-19. Experts say these two groups have less access to health service, have low vaccination rates, and are more likely to have jobs that put them in contact with the public. That's all from my side. Over to you, Mehmet. Thank you.
Thank you, Lieutenant Colonel Panovsky. Thank you for your elaborate insight on the ways that the USA is dealing with the virus. Now we will jump over to Japan, which will be presented by Major Gennady Kolev. So the floor is yours.
Thank you. So, due to a particularly strict approval process, Japan was slower than most developed countries to approve and roll out vaccines. The Pfizer-BioNTech jab was the first to be given to the go-ahead on 14th of February this year, with healthcare workers at the front of the queue. The government has enacted a law to make coronavirus vaccine free to residents. Vaccine rollout began for a general population on 12th of April, starting with over 65s. As of 21st of May, Japan has approved the use of Moderna and AstraZeneca vaccines. Those over the age of 18 will be eligible for the Moderna vaccine, but the Japanese government has decided to initially pause the rollout of AstraZeneca vaccine until they understand better the side effects. This was of particular importance to the government, as they had to put in place a law to treat for more free any potential health problems coronavirus vaccine case. Today, 80% of the elderly in the country have received at least one shot of a coronavirus vaccine so far, and more than half of them have been fully vaccinated with 2 shots. The latest government data shows that more than 28 million people, or 79% of the elderly population, have received their first shot so far. Also, approximately 8.5 million people, or 52% of the elderly, have been fully vaccinated with their second shot. The percentage of all people who have received their first shot, including medical workers and younger people, stands at 32% of Japanese total population. The percentage of those who have been fully vaccinated with 2 shots stands at 20% of the population.
Major, can we have your final assessments due to the shortage of time?
Okay, what is most striking from those above statistics are the all-round low numbers. Confirmed cases, death, active cases, and number tested are still low in Japan compared with other hotspots around the world. So why is this? This is my conclusion. Numerous theories have been provided so far. These range from the more reasonable access to universal health care, early and effective communication to avoid closed crowded spaces with close contacts and cultural norm of mask wearing, to the more far-fetched. For example, some have argued that Japanese is spoken more delicately than other languages, and therefore speakers emit fewer speed particles. Whatever the reason for Japan overall success, they obviously working. Thank you, Mehmet. Over to you.
Thank you, Mr. Kolev. Now we will present a few regional and international organizations and their policies on the issue of COVID. We will have we'll speak about the African Union, and the presenter will be Lieutenant Colonel Valentin Parvanov. Floor is yours, sir.
Thank you, Mehmet. So, after AIDS and Ebola epidemic outbreaks, African unions came up with a conclusion that the continent needs an additional organizational body to cope with health outbreaks. So, in January 2016, by the 26th Ordinary Assembly of Heads of States and Governments, African Union established Africa's Center of Disease Control and officially launched in January 2017. That came up to be very handy on 2 years later. Africa CDC, a specialized technical institution able to support public health initiatives of member states and strengthen the capacity of their public health sectors, and to help detection, prevention, and respond quickly and effectively of disease threats. Here are some major capabilities of Africa CDC. One of them is establish early warning and response surveillance to address all health threats and health emergencies of COVID-19 outbreak. Another one is to assist member states to address gaps in capabilities. Such a gap is that one of the country, for example, Zambia, was unable to carry out PCR tests, and they were directed to South Africa, and South Africa came to help out the country. Another topic is to support regional and country level hazard mapping and risk assessment. I should mention here that one of the country denied to deliver data up until November 2020, when on a later stage, its president got the virus and passed away, and officially announced that such virus exists. Another topic is to support member states in health emergency response by establishing response funds, which aims to raise resources to strengthen the response of the outbreak and promote partnerships among member states. For example, free passages of cargo trucks are a partnership amongst African Union countries. And at the end, to harmonize the systems of one united system of collecting data and information management. As I mentioned on panel 1, COVAX is one of 3 pillars to access to COVID-19 tools accelerator. But later on, it turned out to fail its main ability to deliver a vaccine on low-income countries. That's why African Union established African Vaccine Acquisition Trust in November 2020, which aims to deliver COVID-19 vaccines to the African continent with the goal of vaccinating 60% of each African Union country. Under the plan, the African Export-Import Bank and the Trust have signed agreement on behalf of the African Union for an advanced procurement commitment framework to support the member states. In conclusion, Africa was considered as a safe place, but with Delta variant dominance and lack of vaccines at this point, the continent might follow the example of India. That's why such initiatives like African Vaccine Acquisition Trust are crucial for the continent's future. Thank you very much. Passing the floor to you, Mehmet.
Thank you, sir, for sharing us the efforts of the African Union on dealing with the issue of COVID. Up next, we will have the European Union and its contribution on the dealing with the pandemic. The floor will be taken by Siana Mircheva.
Good afternoon, everyone. The European Union has put in place a set of measures and coordination to confront the pandemic and to ensure that the impact on our societies and economies is alleviated. At the same time, the risks of COVID-19 are still high and daily global infection levels are more than twice what they were this time last year. This reflects the fact that despite the progress, the pandemic is not yet over, but it also shows the need and the urgency to continue learning the lessons of this crisis in order to better address the new and emerging threats of this pandemic. The truth for the European Union is that just like almost every other region and country across the world, neither European Union nor the member states were ready for this pandemic. Preparedness and planning were exposed as being underfunded and underdeveloped, and much of the European response had to be ad hoc and temporary. Coordination and cooperation between member states was often initially difficult and took time to get established and start functioning. This cost valuable time in the early stages of the pandemic, and it showed that the right structures were not in place. During this period, it is interesting that European Union learned 10 lessons. The first one is that it needs faster detection and response that depends on stronger global surveillance and more comparable and complete data. In order to reach that, the European Union should lead efforts to design and implement a new robust global surveillance system based on a comparable and complete data. And there's a new and improved European pandemic information gathering system, which was launched in 2021. Lesson 2, clear and coordinated scientific advice facilitates policy decisions and public communication. That is one of the more important lessons for the European Union. Lessons 3, preparedness needs constant investment, scrutiny, and review. The European Commission has to prepare an annual state of preparedness report to be presented to the European Council and European Parliament. Lesson 4 for the European Union. Emergency tools need to be ready, faster, and easier to activate. Drawing a framework for the activation of an European Union pandemic state of emergency and toolbox for crisis situations. This will be one of the solved problems.
Can we ask you to be brief about, because we're lacking time?
Yeah, lesson 5, coordinated measures should become a reflex for Europe. Reinforce public-private partnerships and stronger supply exchange are needed for critical equipment and medicines. And just one more, a pan-European approach is essential to make clinical research faster, broader, and more effective. Capacity to cope in a pandemic depends on continuous and increased investment in health systems, and pandemic preparedness and response is a global priority for Europe. So European Union is working on these problems very hard, and it is trying to do its best.
Thank you for explaining us the approaches of the European Union on the COVID-19 pandemic. Now we pass the floor to Captain Georgios Tsavaras, and he will explain us about the NATO's contribution to the COVID-19 pandemic. Sir?
Thank you, Mehmet. Good afternoon, everyone. Due to the fact I know that we are already exceeded our time frame, I will be as brief as possible. So let's see how NATO coped with this situation. On March 25, 2020, the Secretary General of NATO activated the crisis management mechanism to study the progression of the pandemic and plan a comprehensive response, ranging from coordination transportation of medical equipment to dispatching NATO military doctors to countries in need to assist in the construction of field hospitals. Following these preliminary efforts, NATO foreign ministers authorized SHAPE to create a dedicated COVID-19 task force to operationalize these plans, and in this regard, the COVID-19 task force heavily relied on NATO's main civilian emergency response unit, the Euro-Atlantic Disaster Response Coordination Center. NATO, with EADRCC, stands ready to coordinate assistance requests and offers from allied and partner nations, as well as from the United Nations Office of Coordination of Humanitarian Affairs, in support of the stricken nations. At this moment, the Alliance responds to more than 20 requests for international assistance, which translated into more than 130 offers in support of these requests. It is proven that most of the member states are difficult to react, since each of them needs exactly the same material and equipment. NATO added value in this response due to the ability to offer efficient logistical solutions at the shared transportation cost. To coordinate logistics, SHAPE relied on NATO supporting procurement agency, NSPA, which during the COVID-19 crisis organized rapid, cost-effective deliveries of protected medical equipment through NATO's airlift capabilities. In this respect, and in connection with NSPA, NATO's initiatives, such as the Strategic Airlift International Solution, SALIS, and the Strategic Airlift Capability, SAC, have been vital to the prompt and safe delivery of medical supplies. In numbers, NATO contributes to the fight against pandemic as follows: more than 360 flights transporting medical personnel, more than 100 field hospitals built, more than 45,000 treatment beds provided, more than 14,000 military medical professionals deployed to assist in civilian hospitals, and more than 500,000 troops around the alliance helped respond. Also, 6,000 defense scientists work to improve virus detection and decontamination in order to boost emergency response for our allies and partners. And of course, we have 24/7 support from NATO EADRCC to facilitate medical and financial assistance to NATO and partner nations. In the preparation for future pandemic waves, NATO built a stockpile of supplies and established a trust fund in order to respond quickly to the needs of allies and nation partners. Cooperation with multilateral organizations such as the European Union and the World Health Organization, and also the United Nations, also facilitate the achievement of NATO deliverables. EU also resorted to NATO logistics apparatus to deliver aid between and even beyond EU countries. Another area of cooperation was medical resilience, where NATO and EU built on the experience of multinational medical coordination center and European Medical Command. The goal is the increasing readiness in medical capabilities throughout cooperation between military medical services and civilian health system of member states. In terms of the operational framework, NATO has tackled COVID-19 following the protocol defined for hybrid threats. Due to the nature of dynamics of the pandemic regarding its deadly potential, military activities such as training and exercises were reduced by 33%, with only 20% of personnel involved. In a nutshell, NATO's response to the COVID-19 pandemic thus far has shown that the alliance can play a positive supporting role in helping and responding effectively even to unconventional threats. That's all about my presentation. The floor back is yours.
Thank you, Captain Savalas. I hope all of you have taken notes from both of our panels. So thank you very much for listening to the briefings of our participants. Now we will have a short break, and then we'll start the third panel about final discussions and plus QA. So please be here at 15:45 so we can initiate the final discussion panel. That is all. Thank you.
right, so welcome everybody back from our second coffee break. Hope you had enough time to stretch your legs a little bit. And this is the final discussion and the final panel of this webinar. And it's my pleasure to hand it over to our moderators today. So Virginia and Mehmet, over to you for the final discussion.
Thank you, Gergana. So we now proceed on to the final discussion panel and wrap up. We're going to start with some discussion because we realize like sitting and listening to lectures for this many hours is a bit tiring. So just to reinvigorate the conversation and get people enthusiastic again, hopefully we are going to start with at least 10 minutes of discussion before moving on to some presentations offered by other CMDR COEs, by the CMDR COEs, Ops Lab, and other COEs. So we will start with a discussion based on any questions that you might have had in the last panels. So, for example, looking at the questions now, we have one about why COVID-19 was a surprise for planners and decision makers. So I would perhaps open that up to our internal participants, or if anybody else has any expertise on the subject, feel free to intervene. Perhaps I shall repeat the question. Of course, feel free to use the raise hand function so that we know who wishes to take the floor. The first question asked was why COVID-19 was a surprise for planners and decision makers. You know, where was this level of preparation? We heard about how the EU was behind on this matter. There are many national governments that admit to the same. So I think the question for experts is, you know, where they went wrong and how we could improve that in the future. Would anyone like to comment on this? Okay, so we have a comment from Lieutenant Colonel Alert. Feel free to take the floor.
Yeah, thank you very much. Actually, I cannot respond to this question properly, why it has been a surprise, but I know the crisis should not have been a surprise because in 2002, 2003, we had the SARS-CoV-1 crisis, and the lessons identified in 2003 and 2004 were there will be another one. And in some of our NATO nations, and I speak for Germany, we had an exercise in 2011, 2012, having an epidemia in Germany of that kind. And there were many lessons identified which should not have surprised us nowadays. Thank you very much for not responding to your question, but knowing that we had the answer already in our papers.
You know, especially after the centenary of the Spanish influenza in 2018, there was a lot of exercise and a lot of new research coming out suggesting that pandemics are going to become a thing of the future, and they're going to increase with our level of globalization and climate change and other factors. So no, I agree with you. And, you know, I hear a lot of stories, for example, the French government throwing out a lot of their PPE and masks about a year or two before the pandemic for budgetary reasons. So, I mean, there's those considerations to make. It's, you know, there's always a balance when you're making policy, you know, whether to, let's say, like you put a budget aside for a potential threat, or to keep a budget for something that's actually affecting your country. So it's a political issue also, as much as an economic one. Okay, so anybody else have any comments, or should we move on to the next question?
We can move on to the next one.
Okay, well, I mean, we've also had quite a few. Oh, Gergana, raising a hand. Feel free to speak.
Yeah, thank you very much. I just wanted to add and echo what has been just said. It's interesting how both the risk and the probability of such a crisis have been significantly underestimated. And absolutely, it's not only Germany, it has been all around. especially in the academic and research world. A number of reports have been pointing to the high risks and high probability, actually, of a virus spreading out and becoming a very serious pandemic, especially in a context of interdependency and interconnectedness in which we are currently living, and which is actually providing the arteries through which these viruses are getting into our systems. So this is a very interesting point, which I would say very much merits attention, because this is, I would say, the key to what the way ahead should look like. But I'm really looking forward to hearing from specifically medical experts that are part of this group today. Thank you very much.
Gergana, your notes on preparedness in the future is certainly something that we've identified as a problem in this pandemic, as we have before in other pandemics. So, look, I think we all look forward to governments of the future keeping in mind like the risk that can be posed to so many levels of security, economic, political, social, community, by a pandemic, and better prepare for the future so that we're more resilient. So we've had some questions that would relate back to the Deputy Director's George Savalas' speech earlier on, which was, is this really a NATO issue? Is COVID-19 pandemic an alliance issue? So perhaps, in answer to the question sent in by a couple of the registered participants, there is someone willing here to speak up about whether this is more of a national responsibility or there is a role for NATO as a regional organization.
If may I, Virginia, can you hear me?
Yes, we can hear you loud and clear.
Yes, I of course, each country makes plans her own strategy, but NATO act as a, let's say, coordinator in order to help each state to provide the solidarity between the member states or even partner states. So NATO played more a coordinator role, not a main actor role in this pandemic. And of course, I am absolutely sure, as you could see from the numbers I provided in my presentation, that it was very, very helpful because especially during the initial phase, the states weren't so much prepared to cope with the pandemic. So NATO had the logistic support, had the infrastructure, and has this organization in order to help, especially bilateral solidarity between member states or even partner states.
Thank you. I see that Keith Mills from Mill-Eng has a comment to make on this, so feel free to go ahead.
Yeah, I'll just make the comment that this is actually an interesting question based on some articles I was reading from back home. I'm Canadian, just so everybody knows, earlier today, actually. And it raises the fundamental question about what our countries expect from our militaries. And the point the article was making is that what the population expects from the military in support of the country facing all the various types of threats has changed radically over the 35 plus years I've been doing this. And I think that's probably true in most of our nations. And I think if you just take that a step further, if our home nations expect this sort of support from our individual nations' militaries, I think collectively they're going to start to expect some sort of assistance from NATO, which rightly or wrongly is seen primarily as a military alliance. I realize that's not actually the truth. It's as much a political one as it is military, but certainly back in North America to, most people on the street, it's seen primarily as a military alliance. And I would argue that that's what's going to be expected of us in the future. Whether or not it's really what we're designed for in the first place is another question. As has already been mentioned, there are inherent capabilities we have that can be tapped into. And I'd be surprised if the demand for that doesn't continue to increase in the future.
Thank you, sir. I agree with you completely. I mean, the evolution of the military in terms of what they're expected to do to ensure our individual security, not just collective security, is changing and developing very rapidly. Probably the fastest in its history, let's say. And now, it's not just dealing with pandemics; it's also expected to deal with the consequences of things like climate change. And so, I agree. I mean, it's a good idea to start exploiting these capabilities that Deputy Director John Savas pointed out, and it makes for an interesting time to be part of a military organization.
Yeah, and just to continue and take that back to the previous question, I think it's absolutely fair to say that this should not have come as a surprise to any of the planners. But the underlying issue really is, as has been alluded to, is that preparation costs money. Okay, at the end of the day, beyond a certain level of just awareness and generic planning, real preparation costs money. Well, taxpayers have to be prepared to pay the resources for that preparation. Populations tend to have a relatively short memory. Politicians have a short horizon for which they tend to, support ideas. Our taxpayers are already paying for us as a military. And I suspect in many ways, they would expect us to take on some of that burden of being the ones prepared to step in. Because otherwise, when we start things that seem to make sense to us for national resilience against some of these other threats, if our politicians put forward new organizations and new measures to be prepared for these things, rightly or wrongly, they will probably be seen as things that are competing for resources. And then if you pay for this, what else do I not pay for? And, one of those potential answers to that question is, of course, the military. So it's all very intertwined and challenging. But I think the short answer is nobody should have been surprised, but, preparations cost money, and that becomes very political.
There you go. There's definitely a cost-benefit analysis to be made in these kinds of decisions. I noticed that we've had 2 raised hands, one from Gergana and another one from our participants in Italy. So I suggest we start with the participants in Italy, seeing as we have not heard from them yet. So feel free to join the discussion.
Okay, can you hear me? Yep.
Yes, we can hear you.
This is Lieutenant Colonel Calvo from NRDC, Italy, here in Lessons Learned. About this role of NATO in the management of this crisis, I want to raise a question, actually, because to me, I think NATO should take a more proactive role, at least in ensuring our own activities, operations and exercises. We have a couple of experiences in 1 year ago, one in exercise Loyal Leader in the UK, and the second one here with the Stifas Jackal 21, the CRP we made. And we found out that the activities were able to be made just achieving, I would say, bilateral agreements with the host nations and the participant nations. So my question actually is if NATO should be more proactive in achieving consensus about measures or conditions to actually develop our training activities or our operations.
Thank you for your question. We're going to pass it over to Captain Savaras in answer who will hopefully help you answer your question.
Well, although I'm not a NATO expert, I'm not part of the NATO organization, I'm just a humble deputy director of CMDRCOE. I can say that NATO will involve further in this in situation like this, and will be more capable in the future. But it still stands on each country decision to decide whether to use NATO capabilities or not. So NATO won't force someone to take measures. It all depends on each country decision. But the lessons learned, the lessons identified from this crisis, surely depict to be more organized and even to be more adapted in a situation, in a hybrid situations like this, like a pandemic. So yes, I think in the future, the NATO will involve even more in situations like that.
Thank you, Captain. I saw that there was another raised hand, but unfortunately I can't see who it was. I think it was JCBRN. Correct me if I'm wrong.
I think it was. I did not raise my hand, but you must have read my mind at least. It's a pity that we don't have a representative from NATO headquarters among us from the international staff. Since I have been working for the international staff for a couple of years, I would say, well, we in NATO headquarters, we have the Euro-Atlantic Disaster Response Coordination Center, which coordinates the support of stricken nations, and not only the 13 NATO members, I believe there are 14, 15 partners participating as well. So NATO has some capabilities and capacities, but the nations have to have the will to use them. And of course, I know that there were also many bilateral actions among NATO members. Speaking for Germany, we provided military medical personnel to some nations. We transported patients from some nations to German hospitals and so on, using also military means. The lack might be the willingness of the nation to coordinate more properly through existing organizations. And we should not forget there are other organizations like the European Union as well. And perhaps we should also always consider not to hunt on foreign hunting grounds. Thank you.
Colonel, we will now move on to a few presentations on this section, especially on the modeling and simulation, which will be presented by Major Lieutenant Colonel Konstantin Lazarov from CMDR COE.
In this way, we'll be looking at solutions that we've been offered already by the center itself. And we'll also have, right after this presentation, a presentation from some of the other COEs on their own work in this period. And then we'll have more time for discussion after these, hopefully, if people keep to their times. So, Konstantin, over to you.
Actually, just before to start the Konstantin, may I join the discussion, Colonel Orlenikov? Do you have a time a little bit? Because can you hear me?
Yes, sir. Please do.
Can you hear me?
Yes, we can hear you.
Okay, you can hear me. Yes, I would like to continue because that is a very crucial questions which we heard just a minute ago, and that is the most important thing actually, how to improve our system, how not to be so unpredictable, because we've been in a situation, and most of our center of excellence even were a little bit frustrated from that situation, from the COVID situation, because it was an unpredictable environment, which is completely new, not only for the nations, but also for the organizations, such powerful like European Union and NATO. And we saw that around 6 months, maybe more, we've been unworkable. We can confess very honestly that a long period, even the education and training stopped somehow. We started to reorient it to online iterations and etc. but most of the, even the Center of Excellence, some of our Center of Excellence didn't succeed to reorient our work. We saw also that NATO was not so well prepared for that kind of situation. And we saw that we've been in such a situation that we didn't know a long period our curriculums and courses and education events are they so equal to regular iterations, so online iterations. And still, even we don't have some answers about how they productive are and what are the criteria for that kind. I agree with JCBRN Center of Excellence, which mentioned that we need some kind of more proactive point from NATO IS, for example. And even we saw that that kind of exercises like ERDCC and crisis management exercises, they've been postponed with around 2 years. And actually the first CMX will conduct it next year, planned for 2019. It's a 2 years period, which we were not so prepared for that kind of situation. All this, exactly that is the purpose of this webinar, and how to deal with that kind of situation, which it now is pandemic. Maybe next time will be another hybrid threat, which we are not so familiar. That's why we should be so prepared. And I wanted to take this opportunity to raise and to again these questions which we heard, and actually the next presentation from our laboratory, it's very interesting, and I would like to mention about this one that we tried in that 1 year period to improve our education and training capabilities. And we use that time to develop new tools, new softwares, new kind of iterations of online and even now in hybrid mode. And I can say that it's 100% fulfilled this task, but somehow we tried. And I think that we succeeded in some matter of what we would like to achieve. Something what is very important, and I still don't have an answer on this one, and really would like to try to even to be more close about some kind of answer, is exactly how such powerful organizations as NATO and European Union. Actually, honestly, if we compare both organizations, we can see two different approaches. From the European Union nations, I saw the approach that with providing of additional funding, additional funds, and etc., that should be conclude any kind of responsibility of European Union. From other side, NATO was not prepared in such a great manner and to deal with that kind of crisis. But anyway, tried and do it and have done all efforts and to try to provoke some kind of additional asset. And actually now, in this period, NATO saw that our Center of Excellence network is so capable and so powerful institutions as a network. I mentioned not the different series as a whole network that could provide and could fill that gap. What was very flattering to us and very good approach, because we saw that the capabilities which NATO started to develop since maybe 10 years ago and try to find some appropriate place for that kind of capabilities, data capabilities, I mean, as a COE network. And now we found somehow our piece in the chain of NATO. And that is one good example from that point of view. Of course, I'm sure that we could define more appropriate measures and more faster reaction of that kind. But anyway, I would like to stop on that kind, and that is exactly what I would like to find answers actually on that questions. And I think that we are on the right way and right track, and could continue our discussion. Let's hear Kostadin. Kostadin, please look more enthusiastic about your presentation. And let's see the presentation. Maybe we could continue to discuss. Okay, Kostadin, the floor is yours.
Thank you, sir.
The screen is yours.
Thank you. I'd like first to ask how many minutes do I have in order to present the project?
Hello, Kostadin. Well, we have to keep to the timing and make sure to end at 5 o'clock. So please keep the presentation as short as possible so we have time for the other CUEs to give their own input. I would recommend keeping it to sort of 3 to 5 minutes if possible.
Thank you, Regina. About the project, you can read actually the name of the project. It's very long because we're in the beginning of the development. But next slide, please. This is about COVID-19 wargaming. It means that we are going to assess the impact and the possible solutions for military joint operation, especially NATO joint military operation, and what will be the consequences if such pandemic occur during disaster or other crisis event. So in order to do that, our approach is so-called closed loop algorithm, and you can see that in the beginning we have to model the problem, in our case the virus spread or the pandemic situation. Then these results, computed results, are transferred to a simulation or virtual environment where we can see what is the result, what is the impact of the computed virus spread. And of course, later we could assess the results and what is the effect over the performance of our virtual military operation, because we could be affected by the virus, of course, and the opposing forces also should be affected, and the civil population, of course, in our virtual environment. In order to improve the performance, our performance, and to save lives, of course, we can apply some response measures, and these actions are transferred both to modeling and simulation systems, so we can close the loop until we achieve the expected results, and of course they should be according to predefined criteria. Next slide, please. The project team members, University of Geneva, they are going to provide us with the COVID-19 mathematical model. I'm going to talk a little bit later for this. MAC Technologies with specific simulation, and CMDR COE with its a specific technical platform or crisis management, disaster response, integrated development environment, and with development of specific NATO standards. This is a standard called NATO Education Training Network. Next slide, please. What we already done is based on our previous experience with proof of concept and wildfire used for this proof of concept. So in this case, we used our platform plus connected German simulation system named Cora. And in order to do that, our disaster module computed the wildfire as an object. So this is the engine where the disaster was computed, the engine of mathematical model. We used two modified simulations because both of them are military simulations, both Cora and Master Sword, in order to work and to deal with such disaster or crisis events, something different from the war and military operations. They should be a little bit modified. What does it mean? When we have computed such object, big scale event like wildfire, the simulation should be modified in manner to receive it, and later this object to have a specific impact over the environment, our forces, opposing forces, infrastructure, etc., etc. Not just this, but also the actions and orders which we could transfer to the orbit or to our forces in order to deal with the disaster. In order to do that, it was necessary to develop specific standard again. This is part of HLA form or Newton standard to exchange information about both objects and something like BML or battle management language. Next slide, please. The crisis and disaster mathematical model. So it's very important to have a mathematical model which is capable to work, to be precise, adequate at the same time, because we need a lot of inputs there, not only like the mention on the screen, population size, density, culture, traffic parameters, etc., etc., but also the applied measures, because if our models can't take under consideration wearing of mask, for example, the result will be the same with or without mask, and we have to avoid such problems. The computed results later could be in different shape and form. On the slide is mentioned just one example of such results. It could be a snapshot of the process of the distribution of the virus, for example. It could be every 5 minutes or 5 hours or 1 day. Next slide, please. The simulated environment, again, modified simulations, adequate simulation offloads the model. I need more time to explain this sentence. And runtime, it's something different from the real time. Runtime is the time in which running the simulation system, it could be much faster than real life time. Next slide, please. The Newton standard, which I mentioned already, again, our Center of Excellence is going to build the necessary standard in order to exchange data about this medical problem, let's say, and this data should be transferred between different systems, modeling systems, simulation systems, and situ systems, and between them also. So first time talking about wildfire, we relied on experts, firefighters, on already developed civil standards, and we transferred the knowledge to the Newton standard, building such a module to it. And this time, again, we are going to rely on the medical expertise in order to find out what are the appropriate protocols which could give us the answer how to exchange data, what is the appropriate way. And that is from me. I was short as possible. If you have any questions, you can contact later Mehmet or Virginia in order to find out my contacts. Thank you.
Thank you, Kostadin, for offering us an example of technological solutions for mapping and simulating COVID-19 pandemics, but also perhaps a future pandemic. It's very interesting. Like we had a good chat about this, so I encourage everybody to reach out to Kostadin for any questions, or, maybe at the end, if we have time, we'll have more of a Q&A session. But for now, we'll move on to one of the other COEs, this time represented by Dr. Silke Roll and perhaps her colleagues as well from Lessons Identified, Lessons Learned. So we'll move on to a presentation from the Military Medicine COE. Next slide.
Yeah, thank you for the introduction. Good afternoon, everyone. So, as been told, my name is Lieutenant Colonel Dr. Roll. I'm the branch chief of the South Protective Branch. I will try to give you a short insight of what our branch and the MIMIT COE has done during the COVID-19 to respond to the COVID-19 pandemic. It was a busy 1.5 last years for the MIMIT COE and especially for the Forces Protection Branch. So during the outbreak, the branch supported NATO's response to COVID-19 by providing a platform for information exchange to our nations and institutions. We managed to become the knowledge hub and coordinating hub for the pandemic on the Forces Protection side. We also provided weekly VTCs for SMEs and provide a platform for exchange of information and experiences. And we also provided COVID-19 updates several times a week to inform the NATO community and especially the missions about the latest information on the outbreak. During this time, we identified a new Okay. Could you hear me?
Apologies for that interruption. Please go on.
It doesn't matter. I wasn't quite sure, but you can hear me. Okay. So I will come during this time. We identified all the new gaps within NATO in the field of force protection. So the pandemic clearly showed the lack NATO has for a long time, and several smart defense projects and SMEs pointed out before. And I think we already talked about it. The pandemic, or something like a pandemic, a virus coming to a pandemic, was clearly known by SMEs before that current pandemic. So, for example, the need for coordination capabilities within all fields of force health protection was something we pointed out before to NATO authorities, and that was definitely showed during that COVID pandemic again. During the outbreak, several NATO institutions worked the same issue, but there was no coordination of the work and the outcomes. So that created a high proportion of doubling of works often. There was no chance for capabilities to exchange the work, if not, personally, or there was bilateral agreements. And in the realm of the outbreak response, we again found that NATO has to invest in interoperable NATO tools for infectious disease outbreak detection, for example, like mobile laboratories or also a NATO RDOID. We know RDOID from national standpoint, but until now we do not have a NATO RDOID where nations or missions can rely on. And we found we had some lacks for that, or we had requests for something like that from missions. And often during that outbreak, nations could not send their own RDOID because they need it in their own country. Then the missions were left behind during that pandemic. That also counts for near real-time surveillance tools. So for over 15 years, NATO is planning for a near real-time surveillance tool to find outbreaks within the missions in a timely, near real-time manner. And until now, we didn't, or NATO didn't succeed in creating or programming a tool like that. So that's why the MIMIT started in autumn last year to proactively program a new near real-time surveillance tool, or the first near real-time surveillance tool for NATO. We currently just used it during the ACT Civics exercise, and it proved the interoperability and the deployability of the tool, that's exercise. And that could be something for the later response for the next pandemic or every outbreak within a mission, to find it in a timely manner, and then can prepare, or the forces protection people in mission can be prepared for the outbreak and for the response to the outbreak. Another main first line of defense for preparation for the next outbreak is proper training and control of communicable diseases. And that's also including outbreak investigation. And there we have a lack because it's not mandatory for people working in the full source protection field to have it while going to the to missions. And we really, really would like to get that implemented in the training before going to the mission. That ends my short wrap up. It was really short because on the other side, I have my colleague, Lieutenant Colonel Przemek Omedjek. He's from our Lessons Learned and Innovation branch, and he will give you a short insight to the lessons learned they found for whole NATO, not only for the force protection field. So I will hand over to Przemek. Thank you.
Good morning, good afternoon. I'm Przemek Omelczyk from Lessons Learned and Innovation branch, like Sylvia said. I will try to keep the time frame. So what we did in the onset of the pandemic, we have proactively reached out of the alliance and the partner nation through ACT, ACO, IMS, and COMES to provide assistance with collection of COVID-related observation, and the link on the slide you can see for our ODCR form. What more? We dynamically have collected, collaborated with NATO Joint Lesson and Analysis Center in regards with the sharing the observation to the NATO Lessons Learned portal. The main lessons identified concern. First, it's basic hygiene measures, means the importance of effective public health communication and adherence to basic hygiene recommendations in contain local outbreaks. Epidemic and pandemic includes the use of face mask to reduce the transmission of potential respiratory pathogens. Second, medical supply logistics. NATO units and military medical facilities deploy with sufficient quantities of personal protective equipment and other medical supplies for initial management of the infection disease outbreak among deployed personnel. Additionally, NATO and or the national military forces should maintain bulk quantities of pandemic supplies to ensure resupply of units and missions until global production can be expanded and additional supplies sourced. Finally, ensure the geographical, diverse, and geopolitically reliable supply network. Then next observation, laboratory testing. It's necessary to ensure reliable access to large-scale laboratory testing capabilities to NATO operational support and establish or identify or contract a rapid deployable outbreak investigation team if it is not existing in NATO portfolio. Next observation, medical facility design and preparedness. Biological threats and the certainly of future outbreaks and pandemic need to be taken into consideration the design of deployable medical facilities. The fifth observation, public health subject matters expert networking exchange platform should be established and maintained focused on public health and infectious diseases epidemiology with periodic meeting held to discuss existing disease threat in Europe and in current deployable location, as well as emerging global disease threats. And finally, remote and virtual work. As well, we are observing that the needs to maintain and exercise headquarters and units plans for conducting remote work to include determining and advance which job can be performed from off-site or which reduced physical presence. As well, we are identifying that we are working through NATO with plenty of different video conferences tools. So could be some one which suits for everybody. That's conclude my briefing.
Thank you, sir, and thank you, Dr. Ruf, for your contribution to the panel. We're extremely grateful to have some medical experts in, and I think that you've covered really a lot of the key examples of things that can be done on the force health protection, and that we need to improve on for prevention and preparedness in the future. So, we'll save some time for questions at the end, and we'll move on to a presentation delivered by the JCBRN Defense COE, who also have their takes to give on best practices and lessons learned from the pandemic. So I pass the floor to Lieutenant Colonel Alles.
Yeah, thank you very much. Good afternoon, ladies and gentlemen. I am the Deputy Department Director of the Transformation Support Department and likewise the Section Chief of the Doctrine and Terminology Section of the Joint Civilian Defense Center of Excellence in Vyshkov. What we did during the crisis, I will very brief and very shortly. First of all, one of the advantages of NATO is, of course, that we are all speaking the same language, or better to say, we should speak the same language. But very often it happens that there were in discussion, well, SARS-CoV-2 is a biological agent, it's a biological warfare agent or a biological weapon. This is not true. Because we have some excellent definitions in NATO term, NATO's official database, and I will not repeat how warfare agents are defined. By the way, it's sometimes very funny to listen to very fashionable terms, as I heard today, hybrid warfare, hybrid threat. Also there we have some good definitions, and I have to admit, CBRN, or the employment of CBRN substances, it's not a part of hybrid threat and hybrid warfare. Sorry for that. Nevertheless, so we were concerned, of course, as well. We supported mainly the Allied Command operations, the Comprehensive Crisis and Operations Management Center, known as CCOMC. Besides the MIL Metsui, I believe we are the only center of excellence with operations or operational level relevant element. It's our CBRN REACH back section. So we had to respond to various requests for information on SARS-CoV-2, COVID-19, however you name it. And what we did, we cooperated very closely with the MIL Metsui, because we are working on similar matters. I mentioned it's not a warfare agent, but we learned a lot on biological defense. We supported ACO also within the planning support and the CAT, the cross-functional action team, with assessments and recommendations on CBRN defense capabilities and also CBRN relevant logistics. We contributed also to lessons learned process. What we mainly did, and this is what you see here on the slide, we provided, as we called it, the SARS-CoV-2 response report. That were our findings, and this is the aim of the report that we tried to achieve. I have to say, and unfortunately, actually we provided two reports. The first one, which was published in December 2020, was classified as NATO confidential, because when we are talking about NATO's capabilities and capacities, we identified also gaps and shortfalls. Capability gaps and shortfalls are per se to be classified as at least NATO confidential. So it's impossible for me to speak on our findings. However, if you have the appropriate security classification, and most of the centers of excellence, they do have, and they do have the link, you can get this report from us. We identified and we provided 38 recommendations along all the lines of capability development. known as .mlpfi, Doctrine, Organization, Training, Material, Leadership Development, Personal Facilities, and Interoperability. And we defined the terms a little bit, or the lines a little bit broader. So under doctrine, we did not even look at doctrines. We looked also at policies and concepts. Or under the topic training, we looked also on education, exercises, and evaluation. What we also did, we provided a second report, NATO unclassified, releasable to the public, but we did not focus on our recommendations, because from the recommendations you can deduct capability gaps and shortfall, and then it has to be classified. So this is more or less what I have to report. Very recently, end of July, we provided also a webinar on our SARS-CoV-2 report, discussing mainly with members of the NATO command structure on an unclassified environment, and we decided we will have a follow-on webinar, and I like to advertise it in a NATO secret environment. All our findings you can find on our website, and thank you very much for providing us the opportunity to initiate and start the cooperation with your, in this area, I believe, very relevant Center of Excellence. Thank you very much.
Thank you, Lieutenant Colonel Alert. Again, we're very grateful to have participants from other COEs, because we see this as an excellent opportunity to create a platform between COEs and other participants to increase coordination and cooperation, really, and to ensure that there isn't duplication, or, you know, that people are really using their expertise to the fullest of its abilities. To that avail, we really would love to have any proposals, both from like our own internal staff as to how to proceed on COVID-19 at the center, but also if there's anything, any suggestions from external participants, we'd also be grateful to hear your input. So now we have about 5-10 minutes left for discussion.
Yes, 10 minutes. 10
minutes left for discussion. So we'll reopen it up to questions and discussions. We have quite a long list of questions sent in from registered participants. One of the most interesting I found here was that there was indeed this question about mechanisms within NATO to avoid duplication, one of which noted that there's a lot of different organizations within NATO structures that are producing reports and analysis on the COVID-19 pandemic and its insight. And this participant wanted to know who are these, who has oversight of the reports, and is there any way that we can avoid duplication? So if there's anyone who feels that they can tackle that question, feel free to take the floor. There we go. So we have a raised hand from Lieutenant Alert. So go ahead.
Very, very short. Because in NATO we have the Joint Alert Lessons Learned Center in Lisbon, Portugal. And if everything works properly, all units of the NATO command structures, so all headquarters of the NATO command structures, as well as the centers of excellence, should have provided their lessons. It's too early to talk about lessons learned, but at least their observations and lessons identified to the JALP. And they should be the body to coordinate and harmonize all these findings. And I remember earlier this year, they had also already a workshop, an online workshop on observations lessons identified of COVID-19. Thank you.
Thank you, sir. We also saw that Dr. Ruhl also has a raised hand.
It was the same from my side. I would like to point it out that for lessons learned, we already had that workshop things about talking about medical. So from our side, from Force Protection side, or any medical related capability, I think we had a lot of doubling of works, of updates about the COVID situation and things like that. Talking about ACT, ACO, IMS, ourselves, also JCBR, and I think the only way to avoid that the next time is some talking and some cooperation between these because the forces protection people or SMEs are really rare, and there should be coordinated and cooperating with each others. So sometimes I was a little bit humble that you got the same information from 3 different sources. So that isn't necessary, I think, for the next time. There's need for cooperation, coordination.
Yeah, that's something that's identified for the future.
If I may, just one comment. What we always neglect is somehow the Science and Technology Organization of NATO headquarters, and also STO provided studies on the findings of the COVID-19 crisis, and it has been published very recently. So it's also a big book. STO is the keyword.
Thank you. We'll put it in the comment bar if someone can type it up from the technical side so that we will have it for everybody else's records. We've got a further comment from NRDC in Italy.
Yeah, good afternoon. Excuse me if I didn't prepare any presentation, but I was in exercise last week and I see your email just this morning around midday. It was impossible. But I have just an observation. Because I guess that one important task that our COE has to accomplish is to give again to all the arena scientific point of view, because we have seen with in this 18 months we have has the chance to read also in very important scientific journal, medical journal, some article that had very few scientific method, because there was no peer review revision and something like that. And I guess that our COE can elaborate a very good scientific paper at the end of the day about vaccination, about many features related with COVID-19 and SARS-CoV-2, and without political point of view that we have seen so far. So I guess that we can give this also to the civilian arena, to give this very important work, that is to say again that the science is something that is to do again, to discover the shortfall and to correct them, and at the end of the day to say, okay, this is the point of view, this is the number, this is our method that we utilize to give you the report of this number and something like that. I guess that this is very important, and there should be the start point in order to face the new pandemic when it will arrive.
Thank you, sir, for your comments. We appreciate the importance of science, let's say, over politics with short-term aims. And following up on that, I think Gergana has a raised hand, so I'll let her take the floor.
Frankly, no, Virginia, I was too excited to hear about evidence-based and scientific approaches, especially in light of all the conspiracy theory things that are going on. And the main, as far as I'm concerned, one of the main channels for risk communication has been Facebook. And much as it could be a barometer of opinions, it could also be quite misleading. So I really am coming again back to my initial question on risk communication, because I think that this is a very significant shortcoming when it comes to, I would say, by and large, response to COVID-19. And I would really wish to hear from the floor in terms of risk communication, and especially coordination when it comes to risk communication. Thank you very much.
Thank you, Gergana. We'll see if anyone is willing to take on the question of the best way to communicate risks and counter, let's say, vaccine hesitancy and misinformation on COVID-19 pandemic.
Well, I can try to give it from our perspective. So we done that, our updates for COVID-19 response and what's going on nationally and globally, NATO-wise and globally. And we always tried to give some scientific information about vaccination or all new things around COVID. Unfortunately, I think our updates only has been written by medical people and people who may know about it a lot before they read the update. But I think information is one of the big issues, to give scientific information, but on a way that the normal, not medical related personnel could understand what we try to bring to them. And that's the challenge, I think, in risk communication. We tried it a lot with I think the WHO had done a great job on risk communication and on working against conspiracy and all this stuff. And so we often try to do it with their pictures. They use a lot of pictures to easy understandable give over the information. So I think that's the main thing to work with that for the normal soldier on the field in the missions, to understand why we're doing that. But it's a big challenge, and that's one of the key challenges within such a pandemic or such an special event. Yeah.
Thank you, Dr. Roll. I noticed Gergana has a response to your answer.
Rather in addition, thank you very much, Dr. Roux, and apologies for the mispronunciation, probably. Just wanted to add that what you said also links to what has been previously during this discussion said on reaching out and factoring in different groups that we can actually differentiate across different differentials, actually, social differentials. So one of which is age, disability, gender, and economic status, and so on and so forth. Because again, back to risk communication, it's really, and also planning for that matter, and budgeting. It is knowing who's going to suffer how and to what extent and to what degree. So I just wanted to add these considerations about the different social differentials that need to be factored into any sort of analysis, any sort of planning, preparedness, and respectively risk communication. Thank you.
Thank you, Gary. I think this section has been we have made a fruitful discussion in this webinar. The inclusion of the other COEs was surely helpful on understanding the situation that we're in. We can have so many approaches on dealing with this pandemic, and we have anything else to include on this?
I mean, I really agree. I think this last panel has definitely been the most interesting, not only for myself, but also for participants, for other participants. I've really enjoyed hearing things from different perspectives. And I just want to conclude, perhaps, before we hand over to the Deputy Director by saying, this is really an excellent opportunity for raising awareness and increasing the cooperation between the COEs. And we look forward to more of that in the future, because really when we're dealing with a transnational threat of this kind, we always need transnational solutions which are grounded in this kind of cooperation. So thank you once again, and we will hand over to the Deputy Director for closing remarks.
Thank you, Virginia. Thank you, Mehmet. On behalf of our director, who has an obligation and cannot participate in this session, I would like, first of all, to thank you all for your participation and engagement in today's discussion, which will undoubtedly serve to inform future analytic work on the subject matter in general and to improve the CMDR COE's own output in particular. The goal of this webinar was twofold. On the one hand, to demonstrate the CMDR COE's work on analyzing COVID-19 throughout the past year, and on the other, to provide a platform for best practices and information sharing among relevant holders. With its insightful outcomes, today's discussion testifies to the achievement of the aforementioned objectives. I would therefore like to convey my gratitude to all participants, particularly to the external SMEs from the other COEs who have enlightened us by sharing their expertise and lessons learned. I hope that the information presented during the webinar will serve useful in your future line of work. And I would also like to take this opportunity to emphasize the importance of cooperation and coordination, especially in the face of global security challenges like this one. As working together increases our resilience and strengthens our capacity in the faces of threats, current and future, to our collective security. We're only halfway in this marathon, and we need to remain vigilant and disciplined in order to prepare our societies to face similar threats by building resilience and preparedness. With this, this CMDR COE webinar on COVID-19 is officially closed, and I would like to wish you a pleasant evening, to avail myself of the opportunity to welcome you to the CMDR again soon, hopefully in person, and of course to thank you once more for your contribution. And last but not least, to thank also our interns, both Ms. Virginia Porter and Mr. Mehmet Najib, for their contribution in this effort to organize and to present this webinar. Thank you all. Have a nice evening. Stay safe, and hope to see you soon in face-to-face in the future. Bye-bye.
Bye.